Thank you. Thank you, SAGES, for giving me this opportunity to present Mount Sinai's experience in building a healthcare capacity and sustainability in rural Uganda. I have nothing to disclose. My goal for this talk is really to give a preview of an innovative model to bridge the gap in low and middle income country healthcare delivery systems, and to really show that the use of advanced technology can really help with the transference of surgical knowledge and skills. Surgical care in Uganda, similar to many other LMICs, are very limited, especially in rural area. While 84% of Ugandans live in rural areas, majority of them must travel more than 2 hours for basic and essential surgical needs. There's only one surgeon per 100,000 Ugandans. That's compared to the US, which has about 54 surgeons per 100,000. There's only 0.2 ORs per 100,000 people. And it's estimated that there's 3.6 million Ugandans with unmet surgical needs and 1.3 million requiring surgical treatment that they're not getting. In alignment with the Lancet Commission recommendations, the goal of our project is to really bridge the gap in providing access to care, increase surgical capacity, and minimize the cost for patients, and at the same time stimulate economic growth in the region. The Kyabirwa Surgical Center was designed and funded by the Department of Surgery at Mount Sinai. Our chair of the surgery, Dr. Michael Marin, took a particular interest in global surgery and really had the foresight and vision to implement a surgical center, embedding it with advanced technology and to bridge the gap in surgical care. This center is self-sustained, green architecture. It has 120 solar panels and a generator, a backup generator. It has its own water supply through rainwater that is collected in an underground water tank. And there's a dedicated fiber cable that was dug for about 6 miles from the coastline of Uganda to the surgical center to provide high-speed internet access, and it is very fast. We have a cloud-based Ugandan EMR system with a fingerprint ID for each patient who checks in. This facility is really built by Ugandans and run by Ugandans. We involved local key stakeholders in planning and construction of the center, and there were over 50 men and women from the village that was hired and trained to construct this facility. This facility and its presence really stimulated the economic growth in the area, and there's a lot more shops and sort of pop-up food stalls around the area because of this facility that's there. So far, in the span of 2 years, we've performed over 800 cases. Most of it consists of endoscopies, colonoscopies, hernias, and excisions. All the patients go home same day, since this is an ambulatory surgery center, and there's close follow-up by a community health worker who actually does home visits. I wanted to highlight with this talk the use of advanced technology in bridging the gap, and how we can really take advantage of these newer methods of technology delivery and platforms. So at this facility, we actually perform telesurgery via an augmented reality headset. We've been able to do live pathology readings using a remotely controlled microscope, and finally use communication platforms such as Zoom or Microsoft Teams in order to train our Ugandan surgeon, who has never performed endoscopy previously, on how to do EGDs and colonoscopies. We have performed telesurgery where the Ugandan surgeon is wearing a HoloLens, and the specialist in Mount Sinai is able to give him live feedback and guidance through a complex and unfamiliar case. These videos really demonstrate what I'm talking about in terms of the merits of this technology. There we are. And so this is a case of a patient who had a very large scalp lesion that was concerning for cancer. And Dr. Joseph is speaking with Dr. Peter Taub from plastic surgery at Mount Sinai. And Dr. Taub is advising him on how to do a complex plastic surgery closure of a hatchet flap. Oh, shoot. Okay, hold on. Oh no. Is there sound? Uh-oh. Is there sound on this? Is there sound? There is definitely audio on all these videos. Oh, maybe. Oh. Oh, there we go.
Would it be helpful?
I think that would be very helpful. And I think once you set that corner and we like it, we can put some more sutures towards the tip, towards the hook.
Okay, that's fine.
So one of the benefits of this technology is that you can actually have the viewer can remotely freeze the screen and annotate live by overlaying it with a hologram of the picture. So.
Which I just did. I'll take my pencil, and I think hopefully we can get sutures from there to there, there to there, and then ones in the corner to hold this in up here. Now I would start with that.
Okay.
So we've also installed a remotely controlled microscope, which provides immediate feedback. And here is a virtual call with Dr. Joseph, the surgeon in Uganda, the microscope, and the pathologist, as well as the breast surgeon from Mount Sinai.
Okay. You can zoom in more. Yeah, those are old vessels. This is vascular channel with blood in it. All this reactive stroma.
Great. Oops, shoot, sorry. Lastly, we had Dr. Jerome Wei, who's a pretty renowned endoscopist at Mount Sinai, teaching Dr. Joseph on how to perform colonoscopies. So far, they've performed 95 guided endoscopies, both upper and lower. And it's all done through the Zoom platform.
Go back. Keeping luminum view, pull back. Pull back. Very nice, very nice. A nice maneuver. Okay, now take out a little bit of air.
Great. And then here is the Mount Sinai GI fellow teaching Dr. Joseph on how to do esophageal banding. This is a practice session. Oh, shoot. Sorry. Let me try. Sorry. Go. Why can't I? Okay, I give up. Oh, there we go. Okay.
You rotate this once, and you should feel like a give, okay, like a click, and that's one banding noise. See? Did you?
Yes.
Okay, good. Now let's take a look at your glove and see what's going on there. So release your suction now and.
Wonderful.
We are also in the process of training Dr. Joseph in laparoscopy. We've sent him to India for 3 months for a laparoscopic training course. We are actively, routinely practicing FL skills via simulation using HoloLens, where we're giving feedback to him during these sessions. There was an online training course scheduled for this month. Unfortunately, it was delayed due to COVID. And eventually, once he does start doing laparoscopy, we will be doing a lot of teleproctoring at the same time so that we can ensure that he is safely transitioning into doing laparoscopy. So in conclusion, I wanted to present an innovative approach to bridging the gap in healthcare delivery in rural Uganda. We really used green technology and natural resources to power the facility, and we also used advanced technology to provide a much higher quality of care that would otherwise be unavailable in that region. And in the process, we built self-capacity for the Ugandans. If there's anything I want the audience to sort of take away from this talk, it is that we must sort of think creatively and utilize our own resources to assist in building surgical capacity. There's a lot of talk about utilizing the local resources to the best of their ability to make things happen. But sometimes we really need to just creatively think about our own ability and our own resources, especially in terms of advanced technology. Thank you.